No, it says an attendee. I think it's already started.
No, I'm starting broadcast in 3, 2, 1. Okay, I think we're good to go. Georgia, can you just give us a thumbs up if you can hear me? You turn it up so you should be able to hear me now. Can you hear me now? Yeah, perfect. Okay, good morning. Welcome to today's webinar. It has been a while since we hosted a webinar, so it's great to see so many of you joining us for the session. Today's subject is Mpox and everything you need to know about it. The session will be presented by pandemic planning expert David Hutcheson, who has over 10 years of experience in this subject. You may recognize David from all the pandemic webinars he delivered for us in 2020 and 2021. If you'd like to ask David any questions, please do so by typing in the question box on the control panel to the right hand side of your screen. We will go through all the questions at the end of the session. If you'd like to ask David any questions, please do so. Oh, I've said that already. The session will last a maximum of 1 hour, and a recording of the webinar will be emailed over you to later this week. I think we're ready to begin, so I shall hand you over to David. So,
thanks, Lachlan. Morning, everybody. If I get to be a presenter, I will run you through some slides for this morning. What anybody who's been on talks with me before will probably know what I try to do is make the slides quite comprehensive for you, and that way you can use them again. You can cut and paste stuff out of it. I really try to make it something that you don't need to take a lot of notes, but you can pick anything you want and out of it just make up your own presentations if that's the sort of thing that you have to do. I'm assuming that most or all of you are either in business continuity, maybe health and safety, maybe HR, and you've been asked questions about Mpox. It's one of these things that comes up, and you should be able to take more than enough out of these slides, to be honest. I think there'll be nothing in it that you would need to go elsewhere. I've done all the research really to save you having to suffer some of the research that I do. Hopefully you can see the slides. Now a little bit about the background to it. For Mpox,
sorry,
I
David,
think
can we just get your presentation into full screen just before you start?
it is according to me, but is it not?
Yeah, but full screen. Put it into presentation on the screen because we're just getting the slides down the left hand side and your screen.
Ah. So does that still? It is at my end. Is it not coming through at yours?
No. If you press F5, apparently that might be the thing. It's not playing ball today. Just carry on a bit like that. That's fine. Okay, fine.
Yeah. Okay. I'm a bit stuck with it because it's in full presentation mode. In fact, just give me a second. I'll have a quick look. There's plenty of stuff that I can talk about. The background to the panic in Mpox, I suppose, that came out of this was the World Health Organization declared, what would you call it, a public health emergency, which of course immediately set the media all around the world in a complete panic. It's COVID again, we're all going to die. The usual panic that you get from the media, totally unnecessary panic, to be honest. I can see that you see half of it. It's odd because when I do it, I can see it's full screen to me. Anyway, you're not missing a great deal by that. You get the slides anyway. So, yeah, the World Health Organization started it all with this public health emergency on the 14th of August. That's the second time in 2 years, but it's interesting that the first one wasn't really picked up. Now, the WHO did make it very clear that this is not the new COVID. We're not going back to where we were. They're not seeing this as a global pandemic. But of course, again, the media have to create stories. And if any of you were on the talk I did about the media and false news and all the rest of it, you'll know the reasons behind it. They've got a job to do. And well, I don't think anything was said that was untrue, if you like. You can make the truth many things. So the stories come out. It's not the new COVID. Is it a panic? For most of us, no, it's not a panic. If you are based in certain areas of Africa, then it may well be. It's not a good position to be in. So what the WHO have done, they've produced a thing called a strategic preparedness and response plan, which will run from 1st of September to the end of February 25. And that the first thing they need to do is get a lot of money from those who support it, and that will give them the money to spend to try and prevent the spread. Now, the main thing that this strategic response plan is there to do is to try to stop the people-to-people transmission. So that's the kind of core of what this is there to do. I'll come on later on to how all of that fits together, but that's kind of the background to it, if you like. The WHO have put all this in place. They do that in some ways, and I'm not criticizing them at all for this. It's how it works. They put these things in place to get the money to let them react. The WHO are very much dependent on groups, governments and others who provide them the funds. I mean, you're talking of something like $80 million they want to deal with the Mpox issue. So we're not talking about small sums of money here. So anyway, a bit of background to Mpox. It was first discovered, I think, in Sweden in research monkeys in 1958. And that's really how it became called monkeypox, because the first time it was found was in monkeys. The first human case, as you see, 1970 in the DRC, which used to be called Zaire, if you're old enough as I am to remember these things. It was called monkeypox until 2022. Now, the WHO, as any of you who will have been involved in the pandemic, the COVID pandemic, will realize that the WHO made some decisions to change how things were named. We had the Spanish flu of 1919, the Hong Kong flu, all of these things. And there was a feeling that was kind of stigmatizing somebody for it. And certain people did call COVID the Chinese flu and all the rest of it. So they now avoid that type of thing. It has been called monkeypox for a year. They changed it to Mpox. The other thing about it, of course, is that it's not only found in monkeys. It's not as if monkeys are the only source. It's found on a great number of small rodents and other animals that you kind of loosely would determine as bushmeat. So it sounds a bit, the way it was announced, it sounded like they were trying not to offend monkeys, to be honest, which again, was not the way it was meant to come out, to be honest. But the idea is just to say that it's monkeypox gives a misunderstanding of the kind of reservoir of the animals that could cause this for you. Where is it most prevalent? Well, pretty much where you would expect, if you think of the background to it. It's largely across the central strip of Africa there, with the kind of core of it sitting in the DRC. They have by far the highest number of cases. There's about 18 to 20 countries have registered cases of it. There's one in Sweden, I think, at the moment. The Philippines have a few. The USA, I think none at the moment on this particular round of it. So you can see that the problem lies really in that Central African area. That's where the large concentration of this problem sits. Now, a bit of kind of explanation about all of this and the vaccines and the words you'll hear and all the rest of it. Two types. Clade 1, which is the one that we're dealing with at the moment, the more serious one, and Clade 2. They were called Congo Basin clades, West African clades, the number of names. Clade 1, especially Clade 1b, is what we're dealing with at the moment. It is the more severe one. Now, a lot of figures are quoting factors of a 10% fatality rate. There's a number of things that you need to watch for that. First of all, that is based on fairly unclear numbers. It's not clear that is exactly what it is. It may well be considerably lower. A number of places I've seen are saying it's more like 2 to 3%, which is not small by any means, but to keep it in perspective. And Clade 2, more or less, the fatality rate is very low. But and just so that we can clarify, if you hear all these, a clade, it's a biological term for how you define things. And there's kind of three levels that you start at. There's the strain, which is a very wide term, and biologists and scientists don't like it because it doesn't really mean anything. It's a widespread term. There's a strain of a virus. It doesn't define it. There's a
Sorry, Dave.
Yeah.
Sorry, David, to interrupt you. Just we seem to be stuck on the first slide,
Ah,
and I just thought there's a couple of people have asking you to move it forward. There we go. That's moved forward. So you might have to do it manually.
is that working?
Please go to map slide. I think it is now, but you might have to just manually make sure that it moves forward if that's all right.
Yeah, it's obviously not running on presentation mode. So, okay, sorry
Perfect.
about that.
Thank you. That's okay. Carry on.
I'll move it forward that way. Yeah, the virus types, as I say, a clade, or the highest level is a strain, which doesn't mean anything. A variant, we'll have heard a lot of that in COVID. That's a bit more specific and tends to be the kind of the thing we heard a lot. And a clade is even more specific. It kind of defines it down to able to say more or less what it is. A clade, it's a bit like something that has a common ancestor. So Mpox has a number of clades that go down. I don't know if that's very clear, but you hear the word clade quite a lot, and it just means that is a kind of specific definition of what the virus is. Now, the spread this is the current spread, but I just thought I would mention the kind of one of the well-known ones if you read up on it. Back in 2003, there were quite a number of cases in the Midwest of the USA, and it would have been clade 2, I think, because it didn't seem particularly serious. And that came about because there were rodents being imported from Ghana, I think it was, to be sold as pets, really. And they were often, especially in a couple of cases, they were kept in the same area as a creature called a prairie dog, which is indigenous to the States, and they passed it to the prairie dogs. Prairie dogs, if anybody has any interest in these sort of things, first of all, they're not dogs. They're a strange thing called a ground squirrel. They're a burrowing squirrel. No, a burrowing squirrel. I should never have tried to say that one. Wee furry things, and absolutely not like a dog in any sense, but they're called prairie dogs anyway. And the small rodents being brought in from Africa passed it on to them, and they passed it on to humans. There's no real evidence of fatalities, but that was one of the well-known ones, and then that kind of disappeared. Then we moved into the kind of current spread that's happening, and you can see from the numbers on screen there, assuming you can see the numbers on screen, obviously, given the problems I'm having, that it's increasing rapidly. Those numbers are concerning. They are coming from, especially the DRC, but that area. And what we also need to think about for the reporting from that area is there isn't really, in many areas, a health service that we could rely on for these numbers. So these kind of have to be looked at, I would suggest, as the lower end, possibly not the fatalities, but certainly the number of cases. And anybody who's heard me talk before know that I absolutely do not like to try to make things sound worse. But I do think in this case there's a risk, given the countries we're dealing with, that we're just not being told or not knowing that there's a bigger quantity than we're hearing. So just keep in mind that these are probably at the lower end of how well it's spreading, and it is spreading quickly. What we are seeing really is a bit of more human to human transmission than we were before. So the first thing is, how do you get it? And the main cause, certainly for clade 2, is direct from infected animals. And that is what's happened, or where it started with the DRC and countries round about it. They eat bushmeat, which is as you would expect in those countries. A lot of the animals or some of the animals are infected, and that's how it gets into the human population. How do you spread it otherwise? Now, this is something that we need to be cautious of the media again here. The media really have, certainly some of them, have turned this into a kind of gay plague issue, which is very unfortunate and suggests what some of the media are like, and how they're homophobic. They were aligning it to AIDS, which is utter rubbish. But there is definitely that I've seen quite a number of articles saying that gay men are the biggest risk, are at biggest risk, and that's taking 2 and 2 and getting it 22 rather than 4. This is not as easily spread as COVID. It can spread through droplets, but it tends not to be. This infection usually comes from face to face, and not just passing somebody in the street as we always thought COVID would do, but it's more about skin to skin contact, especially sexual contact, kissing, those sort of things. That is how it spreads most. Now, the gay thing came out from the fact that there is a suggestion that gay men have a higher number of sexual partners, and therefore there is a higher risk of them spreading it. So again, that's why I say they take 2 and 2 and make it 22. But definitely there is a risk for that, any type of physical contact. Part of the problem as well in the Democratic Republic of Congo is it's a country with a lot of problems in terms of violence, in terms of insurrections, and as well as that, it's a big mining function that happens there. That's a large part of their economy in some areas is mining. The miners are transient workers. That brings sex workers. It brings other problems. So that's really how a lot of the infection came about. You can pick it up from droplets on things like towels, on sheets, on these sort of things. So there is a risk in that way. So for those type of physical contacts, it spreads like COVID, but it doesn't spread as easily. Just coughing, sneezing, these sort of things, it doesn't work as quickly as that. Who's most at risk? The usual, who you would expect. The same as ever, weakened immune systems, young people, very old people with history of eczema. It does appear to be affecting people under 16, probably disproportionately at the moment. So again, that's a risk, but that's again what we're seeing in places like the DRC. The symptoms, we've probably all seen the photos of people with pustules on hands, on face, and these sort of things. It generally starts with a rash, and a word, if you want to save it, is prodromal period, which is the kind of period when you have it, but before you actually show symptoms, and that generally tends to be 2 to 3 days, maybe a wee bit more. You'll see there the symptoms are, apart from the swollen lymph nodes, they're fairly generic symptoms. They're similar to quite a lot of things you get until you get the rash or you get a bit more about the lymph nodes. Often it can be misdiagnosed or just not picked up. So it tends to be that it's diagnosed as a number of other things before it actually gets to the point where it's seen as it is Mpox. So you can see that there are a lot of symptoms that it could be. Vaccines, yeah, there are vaccines for it. We come to kind of an economic issue here. The vaccines are not readily available and not particularly cheap. The vaccines are obviously generally made by countries in the first world, and they're not as available in the countries that need them, such as the DRC, because they don't have the money to get them. There's a big push, and this is what the WHO are doing at the moment, to try and get the vaccines to the places that need them. Now, the plan for the vaccines is not that they will try to have a mass vaccination process. It's more likely that you will get the vaccine if you show symptoms, because it does seem to reduce the symptoms and the severity quite dramatically. So I think that's at the moment how they're likely to do it unless you are in a particularly high risk group. The vaccine will almost be used as something to help reduce the symptoms, and that's how they're looking at it at the moment. They need many millions of doses. We're some way away from that. At the moment, the plan is there'll be about 2 million doses by the end of this year, 10 million by the end of next year. That's roughly the target. They have been using the smallpox vaccine, and there are a lot of similarities between Mpox and smallpox. They're obviously all viruses. The smallpox virus vaccine is believed to be 85% effective against Mpox. So there's a number of things in there that are all going to come together to try and make the vaccine available and to prevent the spread of the disease. But mass vaccinations are certainly not planned, and there's no suggestion that in the West in any way that there will be a vaccination program. It would only be given to someone who either shows symptoms or who is in some way in a group that might have been affected. How to prevent it? Well, if you're in any of the African countries, the first thing is to avoid infected animal meat. It's very hard to tell if the animals are infected, so that is a difficult one. The rest is what we saw with COVID, is what we've seen with Ebola, with plenty of other diseases, a high level of taking care in terms of washing your hands, ensuring you disinfect surfaces, these sort of things. Do we need to do those things in places like the UK or in the West? Not unless you have any belief that there is somebody who has been recently in that area of Africa, I would say. It's not, we don't need to step it up. If you have nobody who has been near that area, there's no reason to believe that you need to change the processes that you have in place. Diagnosing it is the difficulty, and this is why the numbers that we're seeing coming out of the Central African region are at best estimates and possibly not wholly accurate estimates. The diagnosis is generally done by some sort of test. What you see there, a PCR test in a lab. Now that is not readily available in many areas in places like the DRC. So you can't be sure that it is Mpox until really it's developed, especially with the swelling and the pustules that appear. For the vast majority of people, and it is the vast majority, it's a self-limiting disease. You just get better. It's unpleasant, you feel rubbish, but you will get better. And it'll take maybe up to a month for that to happen. There's no specific antivirals. We don't have anything at the moment, Tamiflu and these sort of things that work. There are some that are being tried that may work. The vaccine is probably the most effective thing at the moment. You may get, because you're being affected by it, you may get secondary infections, in which case antibiotics will work, but the antibiotics will not work on Mpox itself, given that it's a virus and therefore it won't work on it. And again, it's really, because for most people it won't be a hugely severe illness or limiting illness. It's a case of taking the usual ibuprofen type medicines, drinking plenty of water, and waiting it out. So that's really how it looks. How severe is it? Well, for most people, not very. Unpleasant, but survivable. You know, it's like COVID in that respect. An awful lot of people had COVID. I mean, I've had it, I think, 3 times. You feel rough and you get over it, and this is much the same. The fatality rates, it's so difficult to be sure. The clade 2, the less severe one, is really quite low, 0.1, even less. Again, as I said, we've seen quotes of 10% for clade 1b. Whether that's right or not, we don't know. I would have thought at anything that is at the higher end, it's more likely to be less. And if you think that this is in countries with poor medical facilities, often poor dietary availability, in countries with difficulty managing to keep hygiene levels high, it's not surprising. It's just not surprising that we get fatality rates like that, which is awful, but it's a fact that we have to face. So again, although there is what looks like a reasonably high possible fatality rate at 10%, the chances are that is driven by a number of factors, and all of them are really driven by the fact of where it is and the facilities available to help people. Can you catch it twice? Apparently. It gives a bit of immunity, but you can get it again. I guess one thing that we should address, and I'll do it in a kind of cautious way, because as ever I don't want to give panic or give anything that might suggest panic. Can it mutate? Yeah, any virus can mutate. We saw that constantly with COVID. Does that mean that it may become a variant or a clade that will spread quickly between humans, people to people? Well, you can't say no to that, because viruses do what they do. And many of the talks that I gave about COVID, I was saying that in some ways you have to look at a virus as a kind of, I know it doesn't, and anthropomorphize and all the rest of it. If you treat it as a kind of a thinking thing, what the virus wants to do is spread. That's its purpose. So it develops ways of spreading. A virus that is very difficult to spread very quickly becomes a non-virus. And at the moment, the Mpox virus, the majority of spreads are in families who have maybe eaten bushmeat and they've spread it amongst themselves. And up to about 6 people is about as many as it seemed to have spread to. So it's not a very efficient virus in that respect. It needs that close contact, possibly sexual contact, to spread. If it was to try and mutate into something that became much more effective at spreading, the view is that it will also become possibly a less severe virus, because the one thing the virus doesn't succeed at is if it kills too many of the hosts. If it was a truly deadly virus that killed almost everybody who got it, it would very quickly run out of people to infect. And that has happened in some of the severe diseases that we see in that region of Africa, that while they might have a very high fatality rate, they actually spread quite slowly, because so many of the hosts sadly die. So although it could mutate, and COVID mutated many times, as we saw, but often it became less severe as it mutated, because it can affect more hosts, but it wants to keep the hosts alive so that those hosts will spread to other hosts. So while we might get mutation, possibly it won't be as bad as all that. And again, it does sound like I'm talking about the virus has a brain. It, in a way, it has, and I'm sure folk will be shaking their heads at me, but it's the only way you can think about it. The virus has a purpose, which is to infect. But to do that, it needs to make itself effective, but not killing the people who get it. So I'm not sure that was very clear, but you can. That is a possibility anyway. That if it mutates, it will eventually become less severe. We hope. And just it's a graphic that I picked up to let you see the difference between the two. There's quite a difference, really. They're nothing like the same in many ways, although they are viruses. The Mpox virus is a much more complex virus than the COVID-19 virus. Although it has less clades, certainly at the moment, it does present a different problem in that it's a much more complex thing. Primary route of transmission, as you see, COVID was very much wear your mask, watch for droplets, all the rest of it. Whereas Mpox, monkeypox, is not. It does need a much closer level of contact, so the risk of it spreading easily is smaller. And animals, yeah, it spreads in animals, so it's not just monkeys. It's any kind of small mammal can potentially carry it. It's not like bats and other things in COVID. So that just gives you something that if anybody asks you what's the difference between them, that's pretty much the difference as we see it. There's lots of stuff out there about it. The best source, I would say, is Africa CDC, Centre for Disease Control. They are at the heart of the problem. They are the ones who are dealing with it on an on-site basis, you could say. So they have a tremendous amount of information that you can get about it. And if you want to see how well things are spreading, I don't know if well is the right word for that, but anyway, you know what I mean. They are probably the best source because they have access to the on-site people. The CDC in the US, always a good source, always got stuff there that can help and give you information. And in the UK, the NHS have got a site about it. Another thing that I heard last night, and I didn't have time to add to the slide, if you go to the BBC Sounds app or any of their online ones, they have a very good program that was broadcast, I think, last week. The program is called The Briefing Room. And if you can't find it, if you want to drop me a message, I'll send you a link to it. But that is a 30-minute program with some scientists directly involved in all aspects of Mpox. And they give a really clear understanding of how, why, where, when, how, all the questions you might want to ask. And it's quite accessible. It's not too full of scientific jargon. So if you want to hear a wee bit more, and you may wonder why you would, but if you did, I would say that's a very good source, the BBC Briefing Room on Mpox, if you do a search for that. But if you can't find it, just drop me a message and I'll send you a link to it. And as ever, those are my contact details. If you've got any thoughts on Mpox, any questions you've got on it, anything that you've got that I haven't got, which there's bound to be. I mean, I keep a library of all these sort of things that I can always supply you stuff from. But if you get anything that you think I might have missed, just send it in, and I'll keep an eye on it. And any of these kind of illness things, I generally have a bit of background information and a bit of a library that I can keep. So if you get a query about anything, like any disease type thing, as Lachlan said, I don't like to call me an expert. I'm really just a sad person who has spent a great deal of time. In fact, it's longer now. I've probably been 15 years, I think. I've been looking at this as a business continuity issue. I mean, I don't have a medical background and make no claims to medical knowledge at all. My involvement in the pandemics and in Mpox, Ebola, all the other ones that I've given talks on, is really, it is a business decision, if I was brutally honest. It's part of business continuity. It's just an area that I've decided that I'll focus on, although I do kind of all the usual business continuity stuff outside that. So if you do have questions about that sort of thing, by all means get in touch. I'm happy to share information to give you anything you need. I mean, I spend a lot of time researching this, and in many ways I do it certainly for our own clients, just so that you don't have to do it. If I was honest, I mean, why on earth would you have to go through all of this reading if you could just find somebody else to supply it? So if you want to get in touch, you can ask me some questions, and I'll do my best to answer them, or just at least give you a source to look for information. And I always try to do something that you can nick from somewhere. So, yes, as somebody who does wear Crocs, I must wait to see if that spreads. So there you go. That pretty much covers everything that I want to say this morning. There's a lot of information out there, but the summary would be, it's not COVID. It's not likely to spread like COVID. It's not the problem that COVID was. It's not a pandemic. It is a health emergency, especially in that central region of Africa, where it is having a very serious effect, and action needs to be taken to deal with it. For most of us, unless either you are in that area or you have people who come and go from that area, you are unlikely to come across it. And if you do, the chances are anybody who gets it will probably get through it and be okay. So is it a panic? No, it's not. It most definitely is not a panic. It is just something that needs to be monitored and something that needs to be dealt with. So I think that we've got 15 minutes left. If anybody does have any questions, I think what I'll do is I'll just call a halt there and then just go over to you. And if anybody has any questions, I'm more than happy to take them.
I think if unless we get some specific questions, I think we can. Well, you've obviously covered it so well that no one is actually needs to answer any questions, to ask any
I've probably
questions.
lost the will to live by now.
No. I think it's been really interesting, and it's good to have. I know you don't call yourself an expert, but I love the fact that you can. Well, we all need someone to quote, expert or no expert, so we can turn around and say, well, David Hutcheson says there's no need to panic. And if we get it, we're not going to die. I think that's what we've kind of taken away from what you've said today, which is pretty positive. And as you said in the beginning, there's lots of things in the media are getting slightly hysterical about it, and it's good to be able to just basically to make us feel a bit more reassured. I think the questions are saying pretty much the same thing. So I will say thank you Thank you. Great session. Thank you to all those that attended and listened in. You will receive a recording of the webinar later on this week, and in case you missed out on any of the content covered. If you have any feedback on this webinar or any topics you'd like to be covered in the future webinars, please get in touch. Otherwise, thank you very much for joining us, and I hope you enjoy the rest of your day.